Hi, this is Melissa Fowler, nursing faculty at Wenatchee Valley College. Today I'm going to be showing you a very basic head-to-toe physical assessment on a real patient. You note that in lecture, I'm teaching you a very detailed and advanced physical assessment within each system. But today I'm going to show you just a very basic fundamental head-to-toe that you can use on almost any patient, knowing that you can always add things to your physical assessment. So this is kind of the foundational, easy head-to-toe. If your patient had a specific problem, like a fracture of the arm, well then you would add different physical assessment data, like you would do a more in-depth neurovascular assessment. Or if your patient had a stroke, you would do a more in-depth cranial nerve assessment. But again, what I'm going to show you today is the physical assessment that you can do for your physical assessment pass-off. Now, I'm going to show you in a way that makes sense to me, that I feel like is easy for the patient, so I'm not getting them up, getting them down, laying them down, sitting them up, because you can really tire out a patient in that way. But know that that's just the way that I'm doing it. You will also find your art as a nurse. You'll find a way in which you'll do your own physical assessment. So when you pass off your physical assessment, you don't have to do it exactly like I'm showing you. For instance, I'm going to do some passive range of motion, but I'm also going to do active range of motion. You probably wouldn't do that if the patient is able to do active range of motion. You would just do all active. But I wanted to show you a couple different ways that you could do either active or passive, for example. So let's go meet our patient, okay? I'll pretend as if I'm walking into the patient room, okay? Hi, I'm Melissa. I'm going to be your nurse today. And today I'm going to be doing a physical assessment, basically checking you out from head to toe, listening to your heart and lungs, checking out your skin. Do you have any pain anywhere in your body that I should be aware of, or discomfort, disability? Nope. Okay, great. Is this a good time to do the physical assessment right now?
I think so.
Great. I'm just going to wash my hands, do some sanitizer here, and I'm going to provide some privacy for us. Shut the door and do the curtain here. So can you tell me your full name and birthday?
Hi, yes, I'm Mr. Peterson James, and my birthday is September 7th, 2000.
Okay, I'm just going to check your armband here, and that looks like that matches. I have a couple other questions for you. Do you know where you are?
Yes, I am at the hospital.
And do you know what month it is?
It is September.
Great. Okay, I'm going to start out my physical exam with just looking at your hair and your head, feeling your head. Have you had any issues with your hair, like dandruff or any lice?
No.
Okay. Any complaints? Any headaches?
No.
Blurred vision, dizziness, anything like that?
No, I don't think so.
Okay. When I'm feeling, does that hurt at all? Is there any tenderness?
No.
Kind of looking in the hair, it looks clean and lustrous. I don't see any dandruff or critters of any sort. Okay, the next thing I'm going to be doing is assessing your eyes and your vision. Can you see me right now?
Yes.
And can you read?
Yes.
Okay. Can you read what's on my shirt here?
Wenatchee Valley College Nursing Department.
Right. Can you see that clock to the wall?
Yes.
And what time is it?
About 4:24.
Okay, great. I'm just assessing your eyes. It looks like they're equal and they're symmetric. I don't see any drainage or any erythema, swelling in the eyes. What I'm going to do now is have you look at my nose the whole time. I'm going to be shining a light in your eyes. Is that okay?
All right, yes.
Okay. Okay. Now I'm going to be, do you see that pillow there?
Mm-hmm.
So I want you to look at the tip of my finger. So you want to get it in the right range of motion. Tip of my finger and then the pillow. Pillow, finger, pillow, finger. and then follow my finger in. Okay, so pupils are equal, round, reactive to light, and accommodation. Okay, now I'm going to be assessing your ears. So, can you hear me?
Mm-hmm.
All right, do you wear any hearing aids normally?
No.
Okay, I'm just going to be looking at your ear here. Any problems with your ear? Notice any drainage or changes in hearing?
No.
Okay, I'm just kind of pressing here. Any pain or tenderness when I do that?
No.
Okay, same over here. Just kind of looking at the outside of the ear, back behind the skin of the ear. Pressing. Any pain when I do that? Tenderness?
No.
Okay. I'm going to be doing a really basic test of your hearing.
Okay.
It's called the whisper test. I'm just going to whisper a word on each side, and I want you to tell me what I said.
Okay.
So can you plug that ear?
Yes. You said baseball.
And then that ear?
Nurse.
Great, you pass. All right, next I'm going to be assessing your nose. Have you had a cold or a cough lately?
No.
Notice any nasal drainage?
No.
Okay. Any like ulcerations or trouble breathing?
No.
Okay. I'm going to tip your chin up. I'm just going to be looking inside your nose. Okay. Nares look patent. I didn't see any ulcerations or particular redness in there. Okay. Next, I'm going to assess your mouth. So I want to ask you some questions here about your diet. Do you feel like you have a good appetite?
Yes.
Okay, so when you eat, do you eat about 100% of your meal or not?
Yeah, usually 100%.
Okay. So, did I ask, are you on a special kind of diets or food allergies?
No.
Okay. What did you eat this morning for breakfast?
I had some toast with jam.
Okay, is that pretty typical for you?
Yeah.
Good variety of foods?
Mm-hmm. Yeah.
Any nausea, vomiting?
No.
Okay, great. I'm going to be looking in your mouth now. Did you just smile for me? Okay, I can see that it's good. Equal on both sides and symmetric. Okay, go ahead and open your mouth. I'm just going to look inside. I'm looking at his teeth. I don't see any ulcerations to the sides. It looks glistening and nice and moist. Stick out your tongue. Okay, and say ah. Okay, you can see that the uvula was midline and rose appropriately. Stick your tongue up, looking below. Really, I'm just looking for any ulcerations, redness, real dryness, and I didn't see that. So, good. What I want you to do, I'm going to test some areas of strength on your body.
Okay.
I want you to shrug against resistance. Okay, good. It was equal strength. I noted that was about a 5 out of 5 on the Levitt scale. So let me see your arms here. I'm just going to look at the skin of your arms. I'm noting that the skin is nice and uniform. I don't see any lesions, redness, rashes. Hair distribution is normal. Here I'm going to check some pulses, checking the radial pulse, and I note that it's +2 and equal bilaterally. And fingers, the nails look clean, less than 3 seconds on cap refill bilaterally. Okay, the hands are nice and warm, not particularly dry. Okay, don't notice any edema either. So edema is 0. All right, what I want you to do now is just do what I do and be strong. Don't let me move you, okay? Okay. Now, I also want you to do what I do, and I'm going to test your active range of motion, okay? So all the way up, to the side, and down. This hand comes around. And same with the other. Give yourself a pat on the back and pat on the back. Great. Okay. Doing okay so far?
Mm-hmm.
No concerns, pain, discomfort?
No.
Great. Okay, at this point, I'm going to be doing an assessment of your heart and lungs. I'm going to start with your heart. I'm going to ask you some questions first. Do you smoke?
No.
Do you have any chest pain?
No.
Or have you had any chest pain?
No.
Okay. Do you have a difficulty breathing at all?
Nope.
Okay. Are you using any oxygen for supplementation?
No.
Okay. What about when you're walking upstairs? You ever feel like really winded, like overly?
No.
You can't catch your breath? Okay. Great. So what I'm going to do is untie your gown from the back, and I'm going to have you hold it. So go ahead and hold your gown. You can just hold it right there. Okay, so first I'm just assessing the skin of the thorax. Again, same, I don't see any rashes, lesions. Hair distribution is normal. And then I come back and kind of do the same thing. I'm looking at the skin of the back. I don't see any lesions, rashes, unusual concerns. I'm going to listen to your heart first. Okay. You didn't have to breathe any special way, just breathe normally.
Okay.
And I will be just listening. Okay, I'm gonna test. I'm gonna be listening to heart sounds in an 8-to-man mnemonic, meaning I'm gonna go for the second intercostal space, just right of the sternal marker. Okay, so that's my first placement, and I'm gonna be listening to the aortic area. I'm hearing S1, S2, no adventitious sounds, no murmurs, no clicks. I'm going to come over here and I'm going to go down 2 spots to the second intercostal space on the right side. And I'm listening to the pulmonic area here. And I'm hearing S2 louder than S1, which is normal. And then I'll pop down to Erb's point. Notice I'm always feeling where I'm placing the stethoscope. Heart rate, not rate, but heart sounds are nice and strong. Again, S1, S2. And then I'm down in the tricuspid area here. And now we're starting to hear S1 louder than S2. I'm actually going to try to feel the PMI, which is the point of maximal impulse. Here's his clavicle here, and I'm looking at mid-clavicular line, 5th intercostal space. So that's here. And actually, I'm going to try to palpate that. And I can feel it really easily. So I'm going to always put my stethoscope right over that PMI for the mitral area. Again, nice strong heart rate, S1, S2, no adventitious sounds. So I'm going to turn the stethoscope around and now go with the bell, because I'm listening for lower pitch sounds and murmurs that I might not have heard the first time. I'm always kind of palpating to make sure that I'm in an intercostal space. Erb's point there, pulmonic area here, and back to my apical area. So when I'm listening to heart sounds, again, I'm listening for my S1, S2, and then noting if there's any adventitious sounds, and that's how you would chart it, S1, S2. I could also gather an apical heart rate at that point. Didn't feel like I needed to. Okay, now I'm going to move to listening to your lungs. So I've already kind of asked you the question, so I'm going to move right into the auscultation piece. I'm going to pop my stethoscope back over to the diaphragm because lungs tend to be more of a high-pitched sound. Okay, can you pull your gown down again? Down to kind of more your belly button. Okay, so lung fields are really not going to go much lower than my ribs here. So what I'm going to do is I'm going to place the stethoscope on your skin, and when I do that, I want you to take a deep breath in and out. And then I'll place it in another spot, and you'll take a deep breath in and out. Let me know if you want to stop at any time if you need to take a break.
All right.
Okay? Okay, you could lift your gown back up. So I heard nice and strong bronchial sounds up near the top, the kind of anterior lung fields, and then more bronchovesicular sounds mid-range, and then down in the base is more vesicular sounds. So it's kind of that upper, more high-pitched sounds here, mid, and then lower pitched sounds. It was nice and breezy. There was no adventitious sounds, no wheezes, no rhonchi, no stridor, nothing like that, no crackles. Okay, so I've kind of hit the front anterior lung sounds, but I definitely want to hear from the back because, as you know, you can hit different lobes easily more in different areas. I want you to take note of the scapula here, okay? So you have the vertebra here and then the scapula here. And then you have this nice prime area right here where his muscles are. And that's where you want to place the stethoscope for your lung auscultation, because you're never going to hear any lung sounds over a scapula or over the vertebra, okay? And then don't forget the axilla area and down on that lateral side. So same thing, I'm going to have you take a deep breath in and out when I place the stethoscope.
All right.
Notice I'm not moving the stethoscope until he's completely done with exhalation. Sometimes I see nursing students moving that stethoscope before they're actually done with the whole exhalation, and you might miss some adventitious sounds if you do that. Again, I'm hearing nice and breezy sounds, vesicular sounds down here, no adventitious sounds. Let's just do two more, one over here, and one more. Great job. You doing okay?
Yeah.
Okay. I'll tie it up here. Gotcha. Now, students always ask me, how many lung sounds do you need to do? How many areas? Because your textbook shows quite a few areas. You do not need to go into every intercostal space and listen to a lung field. And especially where maybe an elderly man might have a respiratory condition and or, they're just old, and so it's more difficult for them to take those deep breaths and they may get winded more easily. And so I would recommend at minimum you do 1, 2, 3 pairs in the front and back, and at least one laterally on each side. Okay, Mr.
Peterson.
Peterson. Excuse me. Can I have you go ahead and, what do you think? What got you sitting? Yeah, I think I'm going to have you go ahead and lay down flat. Cover you up. Okay. And I am going to raise your head just a little bit. So what I'm going to do is do a quick assessment of JVD, or jugular vein distension.
You should say that again. It was going.
Oh, sorry. So what I'm going to do is do a quick assessment of jugular vein distension. Now notice I did put the patient up at around 30 degrees. Let's see where I'm at right now. Yeah, I'm at 25, so let me go just a little bit more. Okay, so now I'm about 30 degrees at a semi-Fowler's position. So go ahead and turn your head so you can see this area of your neck here. So what I'm looking for is a distension of the jugular vein. It'll typically run kind of below the earlobe and down here. This is the sternocleidomastoid muscle. That's obviously not what you're looking for, but you're looking for a big pulsation of a vein here. It'd be like, your vein popping out on your hand here, except it'd be in the neck. And that's an abnormal sign of fluid overload and congestive heart failure. And so I'm just assessing at 30 degrees if I see any vein that's really popping up and distended. I don't see anything on him. It would be okay and normal to just have maybe 1 to 2 to 3 centimeters of pulsation, but on this gentleman, I don't see any at all. So I would say no JVD or JVD absent. I'm putting it down. Okay, now I'm gonna put your head all the way down. Now we're gonna do an abdominal assessment.
You should say that again too.
Now I'm gonna be doing an abdominal assessment. So, Mr. Peterson, we talked about your diet a little bit, but what about your bowel habits? Do you have regular bowel movements?
Yes,
When was your last bowel movement?
yesterday.
Okay, let me go ahead and just expose your abdomen, but I'll keep you covered otherwise. All right, so what I'm doing is I'm just looking at, again, the skin of the abdomen. I don't notice any scars, any rashes, any lesions that are concerning. What I'm gonna do is actually look from the side, and I'm gonna look to see if it's particularly distended. It's flat, so there's no distension noted just on inspection. Now, remember, with the abdominal assessment, we change up our order. We always do inspection, then auscultation. So let's auscultate the bowel sounds. And see, you could just split the abdomen in 4 different quadrants. And I'm gonna listen for a minute in each quadrant. I'm listening for that kind of gurgly, bubbly sound. It should, I should hear a gurgly, bubbly sound about every 2 to 5 seconds. And once I hear that it's active, I can move to the next quadrant if I'm feeling satisfied. And to the last quadrant. Okay, so I can say that bowel sounds are active in all 4 quadrants. Now I'm going to palpate the abdomen. And what I'm looking for is, I'm actually feeling with my fingers, but even more importantly, I'm looking at his face, because I want to see if he has any tenderness or pain when I'm palpating the abdomen. Now, an advanced practitioner is going to go really deep. A more generalist nurse is going to go more moderate to light. So I'm going to be palpating your abdomen. Is this okay?
Yes.
Okay. And so I'm just going about maybe an inch below in every quadrant. Is there any pain or tenderness when I'm doing that?
No.
Pain or tenderness?
No.
Okay. So again, I'm looking at his face, and I'm more concerned if he's like wincing, or if he's trying to push my hands out of the way, then I know that he's probably having more abdominal discomfort than he's letting on. So what happens if there's a patient that's ticklish? That can be a real problem when you're trying to palpate the abdomen. You can put their fingers on their abdomen first, and then you put your hands on top of theirs. You aren't able to feel a lot that way, but you can still assess the pain and tenderness that way. And it usually helps. So I'm just gonna put your head up a little bit just so you're a little more comfortable, but keep laying down. At this point, I'm going to assess your legs. I like to pull the gown up, or the blanket up from the bottom, so they're still covered, I'm only exposing the areas of the body that I'm assessing so that you're maintaining their privacy. So again, I'm kind of looking at the skin of the legs, looking for any scars or disabilities, hair distribution, rashes. Does anything bother you about your skin anywhere on your body?
No.
Okay, no concerns. You can do a popliteal pulse, but in your general assessment, the only ones that you need to do are the anterior tibial and the dorsalis pedis. So here's your anterior tibial. I always find it right behind the medial malleolus. So I can feel that on both sides, and that is +2 and equal bilaterally. And then also you'll find that dorsalis pedis right here on the dorsum of the foot. It's usually a, let's say, more delicate pulse, so you could obliterate it pretty easily, but that's where you'll find it. And also, this one's probably +1 and bilateral. I'm also looking at the toes, especially with an elderly patient. You want to make sure that they're getting good hygiene on their feet, because a lot of times they can't reach their feet. And so making sure that they're nice and clean between their toes, they don't have fungus, that they've been cutting their toenails back. I'm doing a cap refill on both sides. Both sides is less than 3 seconds. Bilateral feet are nice and warm, appropriately moist, not really dry. So I'm going to press really hard over the tibial bone right here to assess for edema. And I don't notice any pitting. Same here. Okay. Now, we did some active range of motion earlier, but I'm going to do some passive range of motion with his legs. So I'm just going to move your legs in different areas. You don't need to do anything at all, but do let me know if it's really, you're having a lot of discomfort or pain. Just relax, let me move them. Okay? And I kind of feel where it stops. Pain or discomfort with that? So then I'm going to go open and then around. Patients with hip problems, this could be really painful for them. So you always want to be careful, pain or tenderness when I do this. No?
No.
Okay. All right, so I would say that's a full range of motion bilaterally in the lower extremities. Okay, what about some strength test? I want you to push on my hands like you're pushing on the gas. Okay, and that was 5 out of 5 on the Lovett scale, nice and strong. And then can you lift up maybe one leg at a time against resistance? Okay, great. Nice and strong. And how about inside? Just resist me. Okay, and same. Excellent. All right, so again, 5 out of 5 strength on the Lovett scale, nice and strong. All right, at this point, we're almost done with the physical exam. I'm going to have you now swing around and sit up like you were before. I'm going to have you actually stand here. You feel okay standing up, not woozy or lightheaded?
Yeah.
Okay, what I'm going to have you do is walk towards the door and then turn around and walk back towards me. At this point, I'm assessing his gait, making sure that it looks normal. No dizziness or whatnot. I wouldn't necessarily send him on a walk if I didn't feel like he was safe. All right, Mr. Peterson, our physical exam is over. I want you to know that I did not find any abnormal signs. Everything was normal and healthy. Do you have any questions for me at all?
No, ma'am.
Okay, I'm gonna go document my findings, and you can be here, and if you have any questions for me, you can push your call button.
All right, sweet. Thank you.
You're welcome.